Good evening everyone. Myself Dr. Jalpa Patel, Junior Cardiac Physiotherapist, Grade 2, working in UNMICRC Hospital in continuous physiotherapy education. Today my topic is peripheral arterial disease. Content of the peripheral arterial disease is introduction, peripheral arterial disease assessment, medical management, physiotherapy management. Before we are going to peripheral arterial disease, we all know structure of the blood vessels. There are three layers in normal structure of blood vessels. Inner layer is called tunica intima, middle layer is called tunica media, and outer layer is called tunica externa. Now we are going on peripheral arterial diseases. Peripheral arterial disease is vascular condition where arteries in your legs, pelvic area or arm become narrowed or blocked, usually due to plaque buildup. This limits how much blood can get through and may lead to symptoms like leg pain. This condition is treatable, especially when diagnosed early. You can see in images, first one is the narrow artery and second one is the blocked artery. In narrow artery, there is a poor blood flow, and in blocked artery, there is no blood flow. Now we are going on introduction. Peripheral arterial disease is a circular disorder in which reduction in blood flow and hence oxygen through the peripheral vessels caused by narrowing, blockage or spasm in arteries. We are going on classification. Arteriosclerosis, there are three types: acute arterial occlusion, chronic arterial occlusion and other aneurysm in gangrene. In acute arterial occlusion, embolism, traumatic infection. In chronic arterial occlusion, there are atherosclerosis, arteriosclerosis obliterans, Buerger's disease, Raynaud's disease and giant cell arteritis. Now we are on acute arterial occlusion. Acute arterial occlusion is a sudden cessation of blood flow to an extremity or organ, typically caused by an embolus or thrombosis. It is a crucial medical emergency requiring immediate intervention within hours to prevent tissue necrosis, limb loss or death. Now key aspect of acute arterial occlusion. Causes are two primary causes. First one is cardiac embolism, that is about 75% of cases. Acute thrombosis of previously diseased artery, often related to peripheral artery disease. Symptoms: sudden severe pain in affected limb, pale or blue skin, coldness and numbness. Diagnosis: often confirmed using vascular imaging including duplex Doppler ultrasound, CT angiography or catheter-based angiography. Treatment or immediate treatment is crucial, involving anticoagulation therapy, that is heparin, and surgical or catheter-based intervention such as embolectomy to restore blood flow. Complications are irreversible. Tissue damage can occur within 6 hours, leading to potential rhabdomyolysis or permanent limb damage. Now signs of acute limb ischemia. There are 6 P's. First one is pain, second is pulselessness, third is paresthesia, fourth is paralysis, fifth is poikilothermia and sixth one is pallor. Types of acute arterial occlusion. First one is acute arterial embolism, that is seen 70 to 80%. In this, clot or debris travel from elsewhere, typically from the heart, due to atrial fibrillation or post-MI, or an aneurysm and plaque becomes stuck in narrowed artery. Second one is acute thrombosis, that is seen 20 to 30%. A blood clot forms directly within an artery, often triggered by the rupture of an underlying atherosclerotic plaque. Other are iatrogenic occlusion, aortic dissection, trauma and compartment syndromes. These all are seen less in all over the people. Chronic arterial occlusion. Chronic arterial occlusion is the slow progressive blockage of arteries, most commonly caused by atherosclerosis, that reducing blood flow to the limbs or heart. Symptoms range from intermittent claudication to rest pain and tissue loss. Diagnosis include ankle brachial index, ultrasound or angiography. Now key risk factor for chronic arterial occlusion, that are smoking, diabetes, high cholesterol, high blood pressure and obesity. Key aspect of chronic arterial occlusion causes are the primary atherosclerotic, smoking, diabetes, high blood pressure and high cholesterol. Peripheral arterial disease often affect the legs, causing narrowing of the superficial femoral and popliteal arteries. Symptoms include painful cramping in calf thigh muscles, which subside with rest and potential non-healing ulcer. And chronic total occlusion is a complete blockage in coronary artery present greater than 3 months, causing chest pain, shortness of breath and fatigue. Diagnosis are peripheral Doppler test, angiography, ABI test. Management of the chronic arterial occlusion is lifestyle modification, medication and revascularization procedure, that is stenting and bypass surgery. Now the other disease is the Buerger's disease. It is also called as thromboangiitis obliterans. It is a rare and non-atherosclerotic inflammatory disease causing segment-wise blockage of small and medium arteries and veins in limb, strongly linked to tobacco use. Key symptoms of this include pain, numbness and blue or red discoloration in fingers or toes, often leading to ischemic ulcers or gangrene. Complete cessation of all tobacco products is the only definitive treatment to halt progression. Causes and risk factors are tobacco use almost exclusively occur in heavy smokers or users of chewing tobacco, with nicotine believed to trigger an immune response that damage vessel linings. Demographics are commonly affect men age 20 to 50 years, through prevalence in women is rising. Immune system is genetic factor including specific HLA alleles, HLA-A9, HLA-B5 contribute to the autoimmune reaction. Symptoms are pain, claudication, vascular changes, tissue damage and inflammation. These are the pictures of Buerger's disease. In this we saw ulcers and painful blue fingerprints, and surgery procedure we do amputation. Now we are going to Raynaud's disease. Raynaud's disease is a condition causing small blood vessels in fingers, toes, ears or the nose to spasm and narrow, restricting blood flow in response to cold or stress. Affected areas typically turn white, then blue and feel numbness or cold before turning red and tingling upon warming. It is managed through lifestyle adjustment to avoid cold and rarely with medication. In these images we saw first this hand is normal circulation, then in Raynaud's phenomenon first white finger due to lack of blood flow, white finger, then lack of oxygen blue and then red. Now we are going on giant cell arteritis. It is a temporal arteritis, is a serious condition causing inflammation of the lining of medium and large size arteries, most commonly in the head. It affects adults usually over 50 years of age and requires prompt treatment with corticosteroid to prevent permanent vision loss or stroke. Giant cell arteritis facts are caused by inflammation in the arteries. Typically it affects people older than 50 years, causes head pain, jaw pain and vision problem, and closely linked with polymyalgia rheumatica. Key aspect of Raynaud's disease: symptoms and attack. Attacks often last around 15 minutes, causing color changes, numbness or pain. It usually affects multiple fingers or toes and is more common in women, especially those aged 13 to 30 years. There are two types. First one is the primary and second one is the secondary Raynaud's phenomenon. Primary is the most common and milder, and secondary is the less common and more severe from the caused by underlying condition like autoimmune disease. Causes and triggers are cold temperature and emotional stress are primary triggers causing excessive narrowing of small arteries. Management of the Raynaud's disease is prevention: wear layers, gloves or heavy socks, avoid sudden temperature changes. Medications are calcium channel blocker we can use, Surgery is the sympathectomy in severe cases to prevent rather than treat severe tissue damage occur. Now, aneurysm-related gangrene. It is a severe complication where a weakened, bulging blood vessels disrupt the circulation of blood, causing tissue death due to lack of blood supply. This can occur when an aneurysm-triggered blood clot or compresses surrounding vessels, often resulting in limb ischemia, fingertip necrosis, or organ failure. Now we are going on assessment of the peripheral arterial diseases. Age greater than 40 years and gender male greater than female. BMI obese. Chief complaint is intermittent claudication. It described as cramping pain during walking, rest pain at night, and pain with elevation, tingling, and numbness. Now, what is the intermittent claudication? Atherosclerosis in peripheral arteries of leg. During exercise, oxygen demand is increased. Due to this, muscle operate anaerobically and after that produce lactic acid and other metabolites, and due to this leg pain occur. Now, medical history. In medical history, diabetes, hypertension, hyperlipidemia, COPD, CVD, and CKD. Personal history, bad habits in this cigarette smoking, diet, which patients are using over junk food, physical activities low level, family history, it is a genetical, socio-economic history, lower socio-economic group, environmental history, exposure to cold. On inspection, change in color, cyanos purple blue and pallor in elevation. Sign of ischemia, trophic changes like diminished growth of hair, shiny skin, thinning of skin, dry skin, abnormal nail growth. In wound, frequent in lower extremity, lateral malleoli, dorsum of foot, toes base is pale and necrotic. On palpation, we can see skin colder than the normal limb, peripheral pulse is decreased or absent, and capillary refill time. Capillary refill time is how to access. So it is accessed by 3 steps and 5 seconds checkup. First of all, press your finger on the patient's nail bed for 5 seconds. Second, release your pressure. And third, count the seconds till the patient nail bed returns pink. Now on auscultation, we can check arterial brute or ABI, lower limb extremity pressure and upper limb extremity pressure. Ankle brachial index. This images show how we measure the ankle brachial index. If ABI value is greater than 1.4, then calcification and vessel hardening is occur. If ABI value is 1 to 1.4, then it is normal. If ABI value is 0.9 to 1, then it is acceptable. If ABI value is 0.8 to 0.9, then some arterial disease occur, and if it is lower than 0.8, moderate arterial disease or severe arterial disease occur. Now we are going on examination. Pain assessment, location anterior or posterior or thigh or calves or foot. Quality, burning or sharp cramping. Quantity, VAS scale, it is also known as visual analog scale. Timing, onset, duration, how long persist, frequency. Aggravating factor, walking up stair, prolonged standing, elevation. Relieving factors are rest, dependent position below heart level. Sensation, we can check loss of light touch, pressure and pain sensation. Now claudication questionnaire is Edinburgh claudication questionnaires. We are asking 6 questions. If the first one is, do you get pain, discomfort in either leg while walking? If the answer is no, then participant screen out, and if the answer is yes, then participant screen in and fill out remaining question. Second question is, does the pain ever begin when you are standing still or sitting? Answer is no. Does this pain occur if you walk uphill or curry? If answer is yes, then fourth question. Fourth is, does this pain occur if you walk at the ordinary pace on the level? If the answer is yes, there is moderate or severe disease, and if the answer is no, there is mild disease. If you stand still, does this pain usually disappear in 10 minutes or less? Answer is yes. Then sixth question, where do you get this pain or discomfort? Calf, buttock or thigh. Now Fontaine classification of PAD. Fontaine classification of peripheral arterial disease severity, grade 1. There are 6 types, grade 1, 2, 2A, 2B, 3 and 4. 1 is asymptomatic, 2 is intermittent claudication, 2A is pain with walking more than 200 meter, 2B is pain with walking less than 200 meter, and 3 is rest or nocturnal pain, and grade 4 is necrosis and gangrene. Now we are going on arterial insufficiency test. First is Burgess test. Patient is in supine position. Ask patient to raise leg one after other keeping knee straight. Legs of normal individual remain pink even if raised to 90 degree. But in case of an ischemic limb, elevation to certain degree causes pain. Angle between limb at which such pallor appears and horizontal plane is known as Burgess angle. Vascular angle is less than 30 degree. It indicates severe arterial occlusion. Second is capillary refill test. Therapist compress nail bed until it turns white and record the time taken for the color to return to nail bed. If the time is delayed, that is greater than 3 seconds, then suggest arterial insufficiency. Other is the rubber of dependency. Non-invasive test examine presence of ischemia following elevation of limb. Lowering limb should return the skin of limb to a pink color. If the color is dark red and takes more than 30 seconds to appear normal, then arterial insufficiency occur. Other one is the modified Allen's test. In this test, radial and ulnar arteries are occluded by firm pressure while fist is clenched until the hand blanches. Hand is opened and pressure is relieved from ulnar artery. Color should return within 15 seconds. This is normal. In these images, we show rubber testing and modified Allen's test. How we apply the modified Allen's test? Exercise tolerance test. Most important test is treadmill exercise testing. Patient is asked about claudication symptoms every 30 seconds. Claudication onset time. First claudication symptoms begins and maximum walking time documented. In this, first one is standardized graded protocol. In standardized graded protocol, first one is Gardner-Skinner protocol. Speed constant 2 meter per hour. Treadmill grade begins at 0% and increase 2% every 2 minutes. Second one is the Treat-Jacobson protocol. In this, speed begins at 2 meter per hour. Grade begins at 0% and increases by 3.5% every 3 minutes through 10.5%. Beginning with this stage 5 grade is kept constant at 10 to 5% and speed is increased by 0.5 meter per hour every 3 minutes. Other one is the standardized fixed protocol. In this, treadmill is set at a fixed grade 10 to 12% and speed at 2 meter per hour or 3 km per hour. Choice is based on practitioner preference as well as participants' exercise tolerance. Other standardized walking test is 6-minute walk test and shuttle walk test. Treadmill test is better functional test than 6-minute walk test in therapeutic trials of patients with PVD. Now we are going on investigations of the peripheral arterial disease. Blood test. In this, high cholesterol, high triglyceride and diabetes. Doppler ultrasound and ABI uses sound wave to see how blood moves through blood vessels. B-scan ultrasound, air plethysmography, digital subtraction and arteriography, angiography and treadmill test. These images show B ultrasound, Doppler USG. In this, plethysmography and angiogram. Now we are going on management of peripheral arterial disease. There are two types of management, conservative management and surgical management. In conservative management, there are medical management and physiotherapy management, and surgical management direct and indirect. Medical management are analgesic, beta blocker, antiplatelet agents, heparinization, low molecular weight dextran, intra-arterial vasodilator, in this lignocaine and papaverine, NSAIDs, in this aspirin, to increase cellular aerobic metabolism, praxilin, to decrease erythrocyte aggregation and increase fibrinolysis, Trantal, improve free walking distance in claudication, cleostazole. Now surgical management is indirect surgical management, sympathectomy, adrenalectomy, division of nerve, tenotomy, and direct surgical management are repair of injured artery, thrombo and arterectomy, arterial bypass grafting, balloon transluminal angioplasty, and stenting, axillofemoral graft and amputation. Now we are going on physiotherapy management. The goals of the physiotherapy management are patient education, how to minimize potential impairment and correct impairments affecting functional capabilities. Relieve pain. Third one is prevent skin ulceration and promote healing if developed. Fourth one is prevent muscle atrophy and joint contracture if patient confined to bed. Fifth one is improve mobility. Sixth, improve walking capacity. Seventh, improve quality of life. Now exercise prescription. Supervised exercise program which is individually tailored for each patient. In this type, aerobic type, mode interval training, duration 30 minutes with rest period in between, can be progressed to 50 minutes, frequency 3 times per week, intensity intermittent claudication rating scale, calf muscle to be spared so that claudication does not limit activity. Now exercise program. This is warm up 5 to 10 minutes of treadmill walking and stretching. Two graded protocols are used in claudication patient. First is Gardner-Skinner protocol and second one is height protocol. Exercise training. Upper limb strength training by weight cups, lower limb strength training by isometric TheraBand exercise, balance and proprioception training, gait training and cool down. Consideration for post-revascularization. Angioplasty patients are ready for rehab within 1 to 2 weeks. Abdominal aortic surgery recovery takes 6 to 8 weeks. Avoid sharp knee flexion in lower limb bypass graft. Prevent kinking in graft crossing the knee joint. Cycling is permissible with proper seat height adjustment. Now psychosocial intervention. In cardiac rehabilitation, professional can assist in 3 ways: by addressing staff concern about general and specific psychosocial concern or presentation by patients, by providing individualized treatment, by providing group psychoeducational presentations, stump management, training for balance and proprioception, gait training. Now we are going on management of chronic arterial occlusion. Management of acute arterial occlusion, bed rest, warming the limb by reflex heating of torso or opposite extremity or elevating head of the bed slightly. Contraindications are exercise, passive or active, prolonged position during bed rest, which could cause pressure on and potential breakdown of skin, local direct heat restrictive clothing. Thank you.